Okay, we'll get started. Hello, everybody, and welcome to Burdon Kemp seminar series, Menstruation to Menopause, and today's seminar, which is on fertility and pregnancy. We hope to break the silence on this under-resourced area. We've worked closely with the Spinal Injuries Association in establishing the speakers, and a massive thank you goes to them to help us in identifying those speakers. Just by way of housekeeping, this is a recorded seminar, but only panelists are visible. If you do have any questions, please raise them in the chat box and we will ask Felicity to answer them at the end of her presentation. That just leaves me now to introduce to you today's speaker, who is Felicity Ashworth. Felicity can bring real insight into this area. She has worked as a consultant in obstetrics and gynaecology at Stoke Mandeville Hospital for 27 years. During her time at the hospital, she ran a gynecological clinic and looked after women with spinal cord injuries during their pregnancy. She now hopes to volunteer within the SCI Women's Health team. We are very lucky to have her join us today. Over to you, Felicity.
Well, thank you very much, and for that kind introduction. And I think it's a wonderful series that has been run. I watched the parenting one last week, and I hope this may be of help. Please interrupt. I realise I can't see the chat box the way I've set my screen up. So if there are questions that are appropriate to answer as I'm going along, perhaps Vicky or Rhiannon could interrupt me. That would be absolutely fine. No problem. As you might imagine, fertility and pregnancy with spinal cord injury is a massive topic. And so what I've chosen some areas to cover, which I've listed down here, and I'm not going to read, but I'll sort out to you, but I'm going to look at fertility issues and treatments and then move on to pregnancy. So I'm sorry if I've got the balance of information wrong. I'm trying to do it sort of succinctly and summarizing, but it's a really important area. And it may not be easy to chance upon somebody who knows more and is more confident about both helping couples to get pregnant and to look after them during pregnancy. But if you look at the figures down at the bottom of my slide, you see that out of the women that are injured worldwide, 18%, so about a seventh are of reproductive age, and of those, about a seventh as well will go on to have children. So don't let anyone say to you can't have children if you become injured. So just a bit of medicine-y sort of definitions first. Infertility, subfertility is sort of known either, is defined as the inability to conceive despite regular intercourse without using contraception for 12 months. So the definition that the sort of medical establishment runs on, which is at 12 months, when I was in younger practice, it used to be 24 months, doesn't really fit with expectations that people have now. And everybody would like to be pregnant the first month they try. But what I wanted to sort of demonstrate is that although we spend a lot of time trying not to get pregnant, actually getting pregnant is not quite as efficient as we might like it to be. And per month, there's only about a 20% chance of conceiving in the first month of trying, which then falls with each month that you try down to around 5%. And just note this, that if you are 40 years and older, that falls to 5% from the beginning. So this is where age is a big factor, and it becomes another stress for women, thinking I should have a baby before I get older. And once pregnant, sadly, that's not necessarily the fact that you will go on to have a child, is that miscarriage will affect up to about 1 in 5, 1 in 6 pregnancies are conceived. And that is not any more common with a spinal injury. So if you have a miscarriage, it's not going to necessarily be because of, well, it won't be because of your spinal cord injury. The most common cause is just that early embryo was not really meant to proceed on to later pregnancy. It's very important with fertility that both partners are assessed. This is not a women-only problem. And in fact, it's about a third become problems for the woman, third for the man, and a third is for both parties, the couple. So looking at those figures, it's really important that you sort of set your expectations and give yourselves a chance to get pregnant, provided things are looking good. And you'll see why putting these provisos is that you're having regular periods, which means that you're making eggs regularly, that they can be ejaculation and into the vagina, or that sperm can be gained by after ejaculation, then inseminated into the vagina, and that can be done at home. So if there are issues, and also if you're sort of in the later 30s onwards, is to seek help earlier, at least by 6 months. And let's move on to sort of what to think about before embarking on deciding to get pregnant or going to a fertility clinic, is to think about the medical and spinal issues that you have, and might any of them affect fertility. You may not be able to have sex, for instance, although if you saw Michelle's presentation, that would be helpful. And might any medical problems affect your pregnancy? Now, none of these tend to be absolutely that you can't have a pregnancy, but they may need to be helped additionally, and seek advice from your GP, particularly things like diabetes. You need to be well controlled before you get pregnant. You may well be taking quite a mixture of medications, and those should be checked to be compatible with being pregnant. Other general things, your smears should be up to date. And if you're finding it difficult to access cervical smears as spinally injured, which some women do, is to ask your GP or the local sexual health clinic, where can you go to access and get a smear? I've put an ideal range for your weight, and this is BMI, which is a ratio of height and weight. And that's the range, that's a sort of normal range. And it can be quite difficult to maintain that weight once you're spinally injured, but is something to consider when you're thinking about getting pregnant. So these are all provisos to sort of think about before wanting to have a child, and also before proceeding with fertility treatments. You're advised to stop smoking completely, preferably not to be using vapes. And to be on folic acid, and that's the average dose, the standard dose of folic acid, which is taken up to 2 to 3 months before you try to get pregnant, and that is to be used. It helps reduce the incidence of the risk of spina bifida. Think about how your bowels and bladder are being managed. Do you need any help to get those optimized before you decide to have a child? And also, fairly obvious, isn't it? But is this the right time to have a baby? Is it you that wants to go ahead with the pregnancy, not somebody else, your mum or somebody else? And don't be so pushed by age. If you're in your 20s, do rethink it in your later 30s. But age should not push you on into having a baby when it's not right for you, or not the right time. And also, are you going to need any help with looking after your baby? And that's covered in last week's seminar. I've put on here a website address of pre-pregnancy advice app, or it's on the website, which is really useful. It's a charity-based program from St. Thomas's originally, but it's a pregnancy organisation. It's got a lot of good information on it. So let's go on to looking at why women don't get pregnant. What's the causes of them not getting pregnant? So I've put it quite simply that maybe problems that you don't make eggs, maybe problems that the fallopian tubes don't allow the sperm and egg to meet, and maybe problems with the actual sperm or getting the sperm into the vagina. Can someone tell me whether my arrow looks as a pointer? Does it work as a pointer for people watching?
Yes.
It does. Oh, great. Okay, so sperm got to get into the vagina, up through this is the cervix, the neck of the womb. This is the uterus here. And the sperm get into here. Here's the ovary from which the egg is released. And it's collected by the fallopian tube here, which sort of catches it, and proceeds down into the fallopian tube, where the egg coming this way meets the sperm coming that way, and fertilization tends to take place in the fallopian tube. And you'll have probably heard about ectopic pregnancies. The most common place that those occur when they're not in the right place, which is in the womb, in the uterus, they occur in this fallopian tube, or the other one, obviously. Okay, so a little bit of anatomy. I hope that's a fairly clear picture. So in order to test those areas, there's some tests, investigations that you will go through. Firstly, the important thing is to give what's known as a history. So you tell your story. And the staff who are listening will be interested particularly in the regularity of your periods, because that often reflects whether you're making eggs and whether you've had any other problems in the past. If I just go back into my last slide, actually, in terms of problems with making eggs, I put here age, being under or overweight. Being underweight is a real issue because it stops the ovaries working and they don't make eggs. And so the best way of treating that is to try to gain weight, although there are underlying reasons why you're losing weight, and it's not as easy as I'm saying. And a condition known as polycystic ovarian syndrome, which is the commonest cause of why women don't make eggs. And then just in terms of the fallopian tubes, is previous infection. You'll all have probably heard of chlamydia. And has there been any surgery? Sometimes people had a very bad appendicitis with infection. It can cause adhesions and scar tissue around the tubes, which means they don't function as well. And if perhaps when you had your spinal injury, if there was any significant abdominal injury, then that might be something to talk to your doctors about. So let's go on to the tests that would be done after that history is taken, have an examination. But the blood tests that are taken now, and here's another complicated graph, which I can only partly see because the pictures of us all in it, but it's showing the menstrual cycle from the beginning, which is counted as the first day of your period to day 28. And that's taking someone with a 28-day menstrual cycle. And the average time of making the egg is halfway through on day 14. Now, the thing if you're deciding you want to test when you're making eggs is that the interval between making the egg and having your period 2 weeks later is fairly fixed. And the time that varies is this time leading up to making the egg. So if you have a longer menstrual cycle, say 35 days, 5 weeks, you will be you'll be ovulating around the time of about day 21 down here. So it shifts everything that way. And similarly, if you have a short cycle, goes the other way. So when you have a test for whether you're making eggs, somebody needs to know how regular your periods tend to be if you have regular periods, and time accordingly. And we do what's known as a mid-luteal progesterone. The luteal phase is after the egg has been made, and the blood test is taken about 7 days from ovulation. And that's the standard type of test. And that's why it needs to be varied. You may find that you might choose to do the tests that you can buy in the chemist, which are known as LH predictor kits, ovulation kits, which actually are testing for a surge of hormone of LH that occurs at the time of making the egg. I find they're quite difficult to read, confusing, and I would encourage people not to go off buying those tests. It's expensive, but it also can add a lot of stress to the aspects of getting pregnant, because then you feel that I must have sex on a certain day. The egg survives a bit before and after. The egg survives a bit after ovulation, and the sperm survive a couple of days. And in fact, the most fertile time to conceive is sex around the time just as the egg's about to be released. So it's far better probably to think of having sex 2 or 3 times a week than to try to pinpoint a specific day, and therefore to get more and more anxious and tense. You may be asked to have other general baseline hormone tests, and this is looking at hormones that are being produced. Often you'll hear the words FSH and LH, and they should be done early in your cycle. The other test that you tend to have done, sorry, I keep moving the slide by mistake, is a pelvic ultrasound. And if possible, that's best done transvaginally. It gives a much clearer picture of the ovaries. We obviously need to be able to get onto the ultrasound couch, and we'll cover things like that in a minute. And it can be done just over your tummy, but for gynae problems, pelvic ultrasound is better. And then how your fallopian tubes tested? The simpler ways are by an X-ray procedure known as an HSG, hysterosalpingogram. Well, there's an ultrasound technique where dye is put into the uterus and can be seen with a scan. And that really combines two aspects of 2 tests. It's called HICOSI. And these are the preferable tests because they don't involve any operation. But if there's thoughts that there may be problems with the fallopian tubes or possibly endometriosis, then a laparoscopy and dye will give much more information. But it is an operation and tends to be just reserved for specific occasions. And then as part of the assessment is are you able to have penetrative sex, or can your partner have penetrative sex? And if not, can there be insemination? Oh dear, I'm sorry, I've got this, it's too sensitive, this slide thing. For the men, can they ejaculate? And having got a specimen of sperm, is a sperm test okay? What is the analysis of this? And it's important that that men are tested. Now, I'm talking here very much male-female couples. It doesn't mean that this is not exclusionary of same-sex couples. Male same-sex is another area that's moving into surrogacy. But for women same-sex couples, they still need to be able to get, you would still need to be able to have sperm introduced into the vagina and the uterus. Okay, let's see if I can make the thing move. Yeah. So what are the treatments? They've covered a bit of the things that might go wrong. Helping to make eggs, there are tablets, and there is one that you may well have heard, often known as a fertility drug called clomiphene. There are other ones that are beginning to be used a bit more. But it's really important that clomiphene and these tablets are to correct problem when you're not making eggs. They are not a treatment for infertility when there isn't an obvious cause. So it's not a question of trying to get pregnant, find all the tests are normal, and then get given clomiphene, because that is not going to help a specific problem. It also has about a 10% risk of twins, and if you can avoid having twins, that's preferable, really. The sperm can be introduced into the vagina, and so if your partner is spinal injured and needs to, has problems with ejaculation and gets a sperm sample, perhaps by a vibrator, verticare, something like that, then that can be done at home once it's been okayed by whoever's looking after you. And you time when you're going to ovulate. And this is these urinary LH tests that I was a little disparaging about. This is one of their roles, is to combine when you're needing to do inseminations at home and home inseminations. And that will help couples to get pregnant. You may move on into a clinic where they actually put the sperm into the uterus itself, which is known as intrauterine insemination. Then you start moving on into more complicated, they're known as assisted conception techniques. You've got in vitro fertilization, where the eggs are collected after being given medications to make a lot of eggs. They're then collected, they're then incubated in the test tube with the specimen of sperm, and then an embryo is replaced back into the womb itself. So as you hear, it's multiple steps. And if by waiting another 2 or 3 months, you get pregnant without any help from IVF clinics, if you don't have other underlying problems, then I would encourage that, because it's complicated, it's upsetting, it's stressful, and it's expensive. The sperm, as part of an IVF technique, instead of just putting the sperm and the egg together in the test tube, you can actually inject a sperm into the particular egg that's chosen, and that is used when there's a very low sperm count. And then another treatment that you may hear of is egg donation, so that if for some reason the eggs that you're making are not very good, the word is used quality, which I think is a very disparaging and not a nice way of putting it, but if you're not getting fertilization, or for various other reasons, it may be decided that you'd use a donated egg. This certainly applies to women in their later 40s or mid 40s sometimes, but that will be advised by the IVF unit. It's quite difficult getting hold of those donated eggs. They're in short supply. And then you'll hear other things, surrogacy, where somebody else carries the pregnancy. Don't dismiss adoption, because this sort of escalating, ongoing treatments are very stressful, often can be difficult for relationships, and costly. And adoption is another area to consider. It's not for everyone to consider. And then egg freezing, which I'll cover in a minute, is something that some women want to consider, but I'll just explain that it's, again, quite a complicated area and not quite as successful as possibly some of the clinics are advertising it. I've just very quickly given, I don't know what my audience is, because sadly I can't see you, whether it's male, female, both. I always worked with a colleague in the Spinal Injuries Unit, one of the male charge nurses in the clinic, and he predominantly looked after the male factor problems that he could treat within that clinic. But it may be a problem of getting an erection, of actually ejaculating, or the sperm that is produced, that their quality isn't very good. And in men who've been injured for some time, often sperm counts are very high, but the motility, the sperm don't move very well, and that doesn't help for fertilization. So what treatments are there for when the problem is specifically male? Is you need to get hold of the sperm, which may be either by assisting or by spontaneous ejaculation. You can actually go and aspirate or get hold of sperm by doing an injection into the scrotum, into the epididymis or testis, and actually getting hold of sperm that way. And one can use donor sperm. Again, it's more difficult to get hold of donor sperm these days than it used to be, but it's certainly easier than getting hold of donor eggs. And then once you've got the sperm, what do you do is, if they can't spontaneously get into the vagina, you can either put them in the vagina just with a syringe, as we talked about earlier. You can put them into the uterus. You can use them in IVF, in ICSI, and you can fertilize maybe donor or frozen eggs. So you're getting a real whistle-stop tour of fertility here. Now, I just put a graph up to show you IVF success rates. The HFEA are the organisation that license all the IVF units in England, and I think in UK actually. And I would recommend their website as being a really useful data source, actually. But here, this shows there's pregnancy, live birth, and a single live birth. Now, the multiple pregnancy, twins and above with IVF was really quite high. It is now down to about 10%. And that is why, unless you're significantly older, the units will only replace one embryo these days. And through the IVF techniques, there are often spare embryos, and those can be frozen to replace at another time. But here you'll see with age, this is actually the birth of you actually here achieve a live birth. And the younger you are, the higher that is. And as you can see, it's only around 30%. So you are investing a lot of emotional time and money for about a 1 in 3 chance of it working. But that's a lot better than what's happening naturally, which is very few pregnancies. And this is and the more goes at IVF you have, the more likely you are to have a baby. So it's a sort of cumulative pregnancy rate. And then if you look down here at the very sad figures for women into their later 40s, there are very, very few pregnancies, and many units have chosen not to treat women over 45 using their own eggs. So hence, but you see, you've got plenty of time to think about things. You don't have to rush to being pregnant. But once you get to nearer 40, do start to make decisions. And what I've put here is what you should be looking for or asking for at a fertility, and I've included maternity unit. When you're making choices, you obviously need somewhere, and I'm telling you things you're very well aware of, but I'm sure you've also found that you haven't had these things when you've gone to healthcare facilities. So you need to be able to access it. You need a bed that allows you to transfer and then to be examined on. If you can't self-transfer, then the hoist needs to be available, and many clinics don't have hoists. The staff need to be aware of spinal injury conditions and be considerate of them and think about it. And I put at the bottom, listen to you, because actually you are the expert patient, and you know what you can do, what is difficult for you, and you'll find that people are quite worried about examining you, how to move you, and you can tell them, so they can help you, you can help them. You want a unit to have a knowledge of autonomic dysreflexia for those of you with higher injuries, and the kit, the postnatal kit that you need to look after a child, was very eloquently explained by the panelists last week, but you'd like a unit to have those. Oh, sorry. I need a lesson, don't I? So I'll just wind up fertility by just looking a little bit at cost. And this is fairly depressing because obviously the costs are going to depend on whether just one person in the partnership needs treating or both. What will what they call the Clinical Commissioning Group, CCG, pay for? And that is the people that commission your healthcare locally. And that varies around the country. Sitting in Stoke Mandeville, I think I dealt with 4 different CCGs, commissioning groups, and they all had different criteria, which did my head in quite often. And sometimes one got it wrong. But you can find that out by working out who is your CCG, and you work that out by which one your GP is, because it depends on where who your GP relates to, not your postcode. So although it's a postcode lottery, it's a GP postcode lottery, not your house postcode lottery. And we had this problem between Buckinghamshire and Bedfordshire of who lived where. And the GPs may need to ask for individual funding. So if they say, oh, you don't fit the criteria, we can't see you, refer you, whatever, there is no reason you can't actually go and talk to people in the fertility clinic and have a referral for discussion. But your GP and then the hospital consultant can also put in a specific request to ask if you can access treatment. And you have to demonstrate an exceptionality. Now, with a spinal cord injury, there are many ways that can be phrased, but it is, why should you get treatment? Why should they fund you rather than your neighbour who also wants to get pregnant and needs funding? So just a very rough idea of what the costs are. And this is why it's really important that in your compensation claims that a sum of money is put in for fertility if you are in a reproductive age group and it's deemed that you may, and who knows whether you want to get pregnant or not. It does depend on what age you get injured. But so anyone who's obviously not in a reproductive age, i.e. Much older, then you're not going to be starting to claim this, because I'm not sure I would encourage women in their later 50s, 60s to start trying to have children, personally. As a personal thing. But as you can see, look at the cost of egg freezing down at the bottom. IVF standardly works out around about £5,000. It does vary, all units are a little bit different, but adding up the costs are very complicated, and you almost need a degree in how to work it out. And there are always additional add-ins that they will give you. But this is where looking at the HFEA website sort of gives you the knowledge to then be able to ask the questions. I'm just very briefly going to talk about egg freezing. As you can see, there's a leaflet produced by the Fertilization Embryology Authority, and I would recommend, if it's something you want to consider. But who would want to move? There's some people who are going to undergo treatment, say chemotherapy, where very much want to save eggs before they embark on treatment that will damage their eggs. They wish to defer a pregnancy, and this may apply in an earlier spinal injury, but within a year of being injured, there is probably no reason why you shouldn't be able to try to get pregnant if you want. So the process of egg freezing is very complicated, expensive, as you saw. Women with age concerns, will their eggs be better if they're taken now when they're 34, as opposed to when they might want to get pregnant at 38? The difficulty is that the actual success rates of frozen eggs leading to a baby are not brilliant. The pregnancy rates are better if the eggs are frozen as embryos, but then that means that you need a partner or you need sperm to fertilize those eggs. And that leads to a whole set of more issues. Is that the person you want to have the baby with? Will you still want to be having a baby within 4 years' time? And here just gives you a rough outline of the costs, because you have to have the eggs collected and frozen, and the cost of the egg collection includes a fairly hefty drugs bill, which comes in IVF as well. You're charged for the storage, and then when you come to want to use the eggs, they've got to be thawed and then transferred alongside fertilization to get the embryo. And they may not thaw, they may not work, and it can be very upsetting, and you may have invested a lot of money. But the current quoted success rates are up to 20%, but that's a fairly optimistic rate at the moment, I think. So that's the sort of drawing my line under fertility. I don't know if anybody because I say I can't see the chat, whether there are questions you'd like that have been asked, and I could cover those in the sort of fertility aspect before I move on to pregnancy.
We have had one question, Felicity. What is the difference between a singleton live birth and a live birth?
Oh, right. That is the live birth. Is that might be a birth within of a multiple pregnancy. So it may be twins or triplets, and the goal is to try to be creating through IVF just a single baby. So rather than a twin. Okay. And the reason for that is that twin pregnancies are more complicated complicated and don't always result in 2 live children.
Okay. I just had one other question, which was just when you were talking about checking like the prerequisites for sort of, maternity units and the fertility, making sure that they've got the right equipment, hoists and everything like that. I mean, how is it relatively common actually that most places can accommodate these sorts of requirements, or do you have to maybe go a bit further afield?
No, I think everyone has to have disability access, don't they? I mean, so there may be almost like lip service to it, and most places will probably have beds that go up and down, so they'd be disability friendly in a sense. But I think probably most places now will have a hoist. But the sort of other aspects of knowing how to deal with autonomic dysreflexia if you have a high injury, having just the sort of a bit of being comfortable with spinal injury, and that's where I think for people listening to this webinar become, as they're the experts, because they can almost help their caregivers to be more comfortable about the issues if they've not dealt with them a lot. But there are, I'm sure, through the SIA, I'm imagining, is that they will have a sort of a knowledge of the units that are much more familiar with dealing with spinal patients. And most of the big cities, because all IVF is, well, almost all IVF is in the private sector. And the issue is whether those clinics, the funding comes via the NHS or whether it's self-funded privately. But most big cities will have a unit that will be familiar now with dealing with spinal cord injury. So you don't have to travel from Newcastle down to London at all.
Fantastic. Rhiannon, did you have any other questions from your end?
No, not at this stage. Thank you.
Okay. Is this the right pace? It's very, not be able to see your audience. It's really...
No, it's going really well. Thank you.
Okay. I'm sorry I can't move my slides correctly. Okay, well, let's move on to pregnancy. And this is, I've taken some highlights or topics or things I want to talk about. But at Stoke Mandeville, we by having the National Spinal Injuries Unit, we obviously looked after women who were patients of theirs and some who came to them. But you see how the numbers are not high. And this is why a lot of obstetricians don't have experience of looking after women with spinal cord injury, because over 25 years, and this was published, well, it's actually only published a couple of years ago, but is the series we took up to 2016, it's only 50 women and 68 pregnancies. So this is not a high number. So perhaps caregivers can be forgiven a bit by not being that familiar, but it doesn't mean to say they can't know where to go and ask for information. And you again, as a patient, somebody in pregnancy, can point your caregiver to where there might be the necessary knowledge. So, and of those that were injured, 2/3 had injury above T10 and a third below T10. And what I've just tried to do is to break it down into looking a little bit at antenatal and then the labour side. But the most important thing is that you are pregnant just as any other woman is pregnant, and therefore you need routine antenatal, midwifery-based and definitely hospital-based obstetric care. On top of which, alongside all the usual issues of pregnancy, you will have some additional ones depending on your level of injury and your mobility and whether you're complete or incomplete, etc. So just to pick out the things that are a bit more common, bladder infection, urinary tract infections are going to affect more women. there may be grumbling background infection through catheters, etc. And so decisions have to be made of when and if to treat those infections, and certainly to stop it spreading to becoming infections in the kidney. Spasms are a nuisance, as you will be well aware, and those tend to get worse in pregnancy. And it is a bit difficult because the medications that you might use for them on the whole would be baclofen. We ask people not to use, and we use oxybutynin, which helps bladder spasms more than others. And also pressure sores. You have to be very careful about your skin care. So all the things you normally look after, you have to look after doubly careful, and transfers with weights. As you become more pregnant, it becomes much more difficult to transfer, and you may lose your balance. Anemia is often cited, so you may well be asked to take iron tablets, which then may upset your bowels. Discuss that with your caregiver. And thromboprophylaxis is prevention of thrombosis, prevention of clots in the veins. The obstetricians are concerned that women in wheelchairs will get significant problems with thrombosis, but actually once past the immediate injury, the risk of thrombosis after about 6 to 12 months isn't any more than anyone else. And so we've advocated using the normal, all obstetricians have a scoring system as to when to prescribe medications to reduce the risk of thrombosis, and spinal cord injury scores as one within that. But you're quite likely to need some injections to reduce the risk of thrombosis after delivery, depending on delivery and how long you're in hospital. But thromboembolism is a significant problem in obstetrics, and so will be being addressed. Other antenatal problems, that of delivering early. Preterm labour is the delivery of a baby before 37 weeks. After 37 weeks, the baby's counted as term. We found a higher rate, up to 18% of our patients delivered before they were 37 weeks. But the important thing was that there was only 1 or 2 women who delivered at less than 34 weeks, when prematurity would be considered more significant to the baby. It still sounds very early, doesn't it, above 34 weeks, but on the whole, the babies will do extremely well and need some extra support with heat and feeding. The background rate of preterm labour in the general population of the UK is about 8 to 10%, so it's a higher rate. And then the other thing that is more common, this is where your obstetric caregivers need to really be on the lookout, is for what's called malpresentation. That means that the baby is not head down. So we like babies to be head down to deliver, but 15% in our series were either breech, that's head up, or crossways, which makes delivery more complicated. And leads to higher cesarean section rates. The background rate of malpresentation at term is about 3%, so it is significantly up, but it's not something that can't be managed. All these things can be managed. Respiratory concerns, particularly the higher the lesion, your injury, and into the higher cervicals, it becomes more of a concern. And also if there are skeletal issues, perhaps a significant scoliosis that's occurred, and that's where assessment of the respiratory reserve needs to be done. The management of autonomic dysreflexia becomes very significant with labour, and I've got a slide to cover that a little bit. That affects women with injuries above T7, so T6 upwards. And then anaesthetic issues, that it's really important that you are assessed by an anaesthetist, partly because you may well need an anaesthetic, i.e. an epidural or a spinal anaesthetic during labour or delivery, the cesarean. But it's also in terms, I don't think I actually did a slide for this, no. In terms of the organisation of where you deliver, firstly you book in pregnancy through your GP and midwife in your community, and then it really depends on the level of your injury and your mobility, and whether you're complete, incomplete, as to whether this can be managed at your local hospital. And there may be occasional times when home delivery might be supported or encouraged or agreed, but on the whole, you'd be looking at a hospital-based delivery. But that doesn't have to be near or in a tertiary centre or a spinal unit. If provided your injury is below about T10, you will notice labour pains. Provided it's below T7 below, you are not likely to get dysreflexia, and these can be managed by a local hospital. But once you're into the ranges of autonomic dysreflexia, you need to be in a unit that's familiar with how to deal with it. And that may not be a spinal injuries unit. There aren't that many that have attached maternity units. But at least probably in what we call a tertiary, so a teaching hospital, a bigger centre, and they should liaise or read the literature about looking after autonomic dysreflexia. I very much encourage women to be delivered as locally as possible if their lesions are below T6, just to make life easier for you. And very happy to take calls and to help. But anyone who is booked in a more central hospital should really have an assessment at their local hospital, so that if something urgently happens, that there isn't time to get to their central booking place, then the local obstetrics service and the anaesthetists have already assessed. So I'm afraid it means double sets of clinics, is to see a local obstetrician anaesthetist and then your place of delivery anaesthetist and obstetrician. So just very quickly, for anyone who's not particularly familiar with autonomic dysreflexia, it occurs for people who have levels of injury of above T6 and above, and its symptoms can be multiple, but really horrible headaches, nausea, blood pressure going up, sweating, very awful sensations. And the thing about the blood pressure is that obstetricians may misinterpret this as being blood pressure of pregnancy, because we spend our time checking women whether they're getting blood pressure problems. And so it can be a bit confusing. What's also confusing is that with spinal injury, your own background blood pressure may be quite low. And so a rise that equates to autonomic dysreflexia may almost be thought of as a normal blood pressure, not a significant one. And so that's where the people looking after you in this point need to be aware of all this. Autonomic dysreflexia is caused by pain, which could be full bladder or bowel. And for obstetrics, it's labour pains and delivery. And so anyone who is susceptible to autonomic dysreflexia will get this related to delivery, unless that's recognised and prevented. And the prevention is an early epidural, or later could be combined with a spinal anaesthetic. And so that's why anyone who's got a higher injury and is going for normal delivery, we would want to see people early in labour and insert an epidural, and then it treats it very well. The thing is to get it in time. These are the medications that are often used, and anyone who gets autonomic dysreflexia is very familiar with all these. But the cesarean obviously will, if it's a planned cesarean, will prevent the delivery-based or labour-based autonomic dysreflexia. So just to give you some idea of what you could expect if you get pregnant and want to have a normal delivery, these are our delivery rates from that series. And 63% had a normal vaginal delivery. That meant without any forceps or von-twos, and another 14%. So over 75% were able to have vaginal deliveries. And I think this is where obstetricians need some familiarity with spinal injury, is that to be confident that women can have a normal delivery if they want. Now, these figures were up to 2016, and practice is changing a bit, and I rather suspect our cesarean rates have gone up since this set of publications. I think they have. But there is no reason to be told that you have to have a cesarean just because you're spine injured. There may be other obstetric reasons that you need to have a cesarean for. So the planned cesarean rate was 15%, and that may be if you've had previous bladder surgery, a TVT, or some other continence procedure. If you've had a previous cesarean, you still can have a normal delivery after a previous cesarean, as you heard on the panelists last week. Somebody was explaining that. In fact, two of them, wasn't it? And people are now requesting cesareans more than they were. And these 8% was cesareans in labour. So another figure for you that could be helpful for any of you who have cervical lesions is that the vaginal delivery rate for women with cervical lesions was this as good as the whole group. So being told just because you're a C4 level injury, you can't have a normal delivery is actually not the case. So just very briefly on postnatal, this is the babies and yourselves. I'm not going to cover breastfeeding. You heard a bit about that last week. Small for gestational age means that the baby is under the 10th centile average for that stage of delivery, number of weeks the baby, how old they were, and is 10%, which is a normal average. So babies grow well. What we tend to advocate is that we do routine growth scans, which not everybody in pregnancy is offered, because it may be quite difficult to measure the baby due to other sort of back problems and scoliosis, etc. Of those babies that were born, only 2 went to the special care baby unit, NICU, 1 at term and 1 the preterm baby. And then length of hospital stay was 5 to 10 days. Now, average stay at the moment is about 1, if not 2. So you're going to be in hospital for a while. Hopefully you can get to a unit will let you stay in, and that is partly to recover and be helped to get familiar with how to look after the baby, to look after the wound. If you've had a cesarean, there's quite a lot more to say about that. And we used to have, and I don't think they've got it at the moment, a place where there was a bed where a partner could stay as well, or a relative, and help. And just another practical thing is that in women with higher injuries, who above a level of, well, about T10, you may not feel your labor, or you're unlikely to feel your labor pains. And so we were encouraging women to come into hospital a week or 2 before delivery. And it was obviously very difficult to predict because, as you saw in my figures, quite a number delivered after 34 weeks. So I'm afraid we missed 1 or 2 babies who were delivered elsewhere. But that's another reason for making sure your local hospital knows about you. And I know there's been one question that was sent in was about the problem of what do you do if you can't feel the baby moving? Now, it depends, whoever asked that question, depends a bit on the level of injury. And at 24 weeks, not everybody in a first pregnancy is easily feeling movements by then. And so it may be that you'll start to notice them a little bit later on. By, say, 28 weeks probably is when you're more likely to be aware. What we didn't recommend women bought baby monitors. I think a lot of my practices in the days before, they were easily accessible and probably not as, they were rather expensive at that point. A lot of women do buy fetal monitors to listen to the baby's heartbeat. I think yes, it can be reassuring, but it can also be quite stressful because it's not always easy to find the heartbeat. And it's particularly difficult to find the heartbeat in a younger baby doing it yourself if you're not familiar with it. So I would suggest wait and see whether you start to notice them. If you've got sensation in your hands, you can put your hand on your tummy and you often can feel the kicks. And then if not, talk to your midwife and discuss it with them.
Felicity, the lady who asked that question, she just put in the chat, she's C5. Right,
okay, so you certainly will not feel the movements in the tummy, but you may through your putting your hand on your tummy. And also the other thing is I've never stopped being interested, amazed, whatever, of how people feel with spinal cord injury. And it's just like with noticing labor pains, there's some way that that sort of pain is alerted, and similarly with movement is that there is some mechanism that things are noticed. I can't tell you what it's going to be. So I would encourage that person to wait a little bit longer. And then if you're not feeling movements by 28 weeks, or you can't feel them if you put your hand on the tummy or your partner, then talk with your midwife. So just my take-home messages, just to finish off, if I've still got time. Yeah, have the baby if you want to and the circumstances are right. Don't let people say you can't because you've got a spinal cord injury. Take care with your weight and keep a mind on your age. Now that's not easy. There's not, yes, it's easy to say that, isn't it? But it's a problem. Get some advice from whoever's looking after you or through the Spinal Injuries Association. You need referrals, preferably from your GP to a hospital fertility clinic, if that's the route you need to go. You may need money, you may either private or insurance funded. And my bottom message is that if you want to have a normal delivery and there are no other reasons not to, you can. Okay, so thank you very much and for letting me talk to you.
Thank you very much for that, Felicity. That was extremely informative. We have had a couple more questions come through that I'd be grateful if you could answer. So one question is about the use of respiratory positive pressure, e.g. cough assist machines or CPAP during pregnancy. Would there be any contraindications?
I have to say I'm not familiar with cough assist machines, but CPAP, I don't think so. I'm just thinking back, actually years ago we did have 1 or 2 women with quite significant respiratory side, and the important thing is this is all multidisciplinary team working and is to be assessed by both your spinal injury consultant but also a respiratory consultant. So the bottom line is no, it wouldn't be a contraindication, but it would need to be your respiratory care would need to be optimized, and the assessments would be made. And in fact, we encourage women with higher injuries and the person with a C, whatever, no, it's a different person, to be assessed and have spirometry or lung function tests, basically, and to make sure, and then very definitely to have an anaesthetic referral and make sure the anaesthetist is aware. So it doesn't stop you having a baby, just make sure everybody knows and the team is talking to each other.
Perfect. And we've had another question. If a client who's struggling having an SPC blocking C4, C5 level, it seems to be positional at the moment due to posture. Are there any options as they reach full term?
Yeah, Tracy, I'd send it to you, Tracy, is what I'd do. I know, Tracy. Yeah, yes, the options are, yes, if the catheter is blocking, it may, it's early in pregnancy, things change a lot as the uterus comes up away from the bladder, out of the pelvis. You may find that actually it all gets better. So as not to rush things just at the moment, because just like without the spinal cord in, without a catheter, there's a real problem of going into urinary bladder retention in this sort of stage of pregnancy in people who don't have bladder problems. So hold on a bit and see what happens, but absolutely going to a urethral catheter on the short term would be an option. Provided whoever's put the suprapubic in is not too upset at losing that channel. And that could be, they have to decide whether they just keep the channel, keep it there, but certainly putting a urethral catheter in would be no reason not to.
Great, thank you. And I think there's just a clarification point. Someone's asked us to clarify, or you to clarify, when you're talking about normal vaginal delivery, are you talking about incomplete SCI or very low paraplegia?
When I'm not 100% sure the question is that the normal vaginal delivery is grouped all the levels of injury, and complete and incompletes are all together in that figure.
Perfect. I think
what was quite interesting actually was that the rates of vaginal delivery were better the higher the lesion, and they were more cesareans percentage wise in the low level, in the lumbar region, and lumbar injuries, which always fascinated me because I always felt it shouldn't be that way around. Excuse me, but yeah, so it's you can't make an assumption just by the level of injury as what's going to happen, and you do have to take other obstetric factors into consideration, such as the growth of the baby, what stage of pregnancy you go into labor at, and which way up the baby is.
Great. And I think there's one final question just before we let you go, which is, would you advise against any bladder medications when trying for a baby?
Yeah, I think I think these are the really difficult things, aren't they? Because one, you don't know how long it's going to take you to get pregnant, and you don't want your life messed up too much whilst trying to get pregnant. It's like coming on and off other medications like painkillers for some people. And so in terms of, yes, I would advise that while you're trying to get pregnant, if you're trying normally to get pregnant, is to stop them, because you don't know when that's going to happen. If you're then going to have to move on to assisted conception, where you know when things are going to happen, then you could go back onto them and then stop. But certainly oxybutynin can be used. We found that was fine, it was okay in pregnancy, and wasn't, there are pharmacy guides to what's indicated and not indicated. It's just that the time that medications are the problem for pregnancy particularly are in the first 3 months of being pregnant. And the first 2 weeks you don't know you're pregnant, because that's before your missed period. But during that time, actually, it's very unlikely the baby gets much of any drug, because there's no blood supply to the baby. But so if you find that you really have to use your medications, this is perhaps be baclofen or something like that, it would just be to stop it as soon as you've missed a period. Immediately you miss your period, and then you won't be using it in that early pregnancy stage. Baclofen is probably best avoided in pregnancy during later part as well, because it can cause some breathing problems for the baby.
Great, thank you. And I think Victoria has another question for you.
Yeah, I was just thinking, well, you mentioned the statistics about malpresentation, and I just wondered whether you had any sort of practical advice and tips if the baby does need to be encouraged to sort of get head down, sort of, is there any advice that you can give for sort of helping baby do that if you are, for example, in a wheelchair or?
Yeah, well, the from a medical point of view, obstetric point of view, we can turn babies, and if what you need to do is first be assessed as to why you think the baby isn't head down, because it may be that actually there's been a pelvic injury and the pelvis is too small to have that baby. So there may be reasons where if you encourage the baby to go head down, you still are very unlikely to get a normal delivery. Similarly, say the placenta is in the way, you've got a low-lying placenta. So you first need an assessment, but then after about 35, 36 weeks, you can have the baby turn to go head down. I think the data on the sort of positions of doing those, one of sort of bending forwards with your knees on the ground, there's not good data on that. So I think from your own point of view, the would be just to be guided by what the obstetricians suggest, and be open to, if you're keen to have a normal delivery and you're assessed that yes, if the baby were the right way up, you could go with having the baby turned.
Okay. Great. Well, thank you very much for your time, Felicity, and you will have seen that we've been getting some nice comments in the chat box about how informative people have found this session. So thank you once again for taking the time out and imparting your knowledge to the group. Thank you everyone for joining us, and we look forward to you joining us next week for the seminar on aging well with a spinal cord injury. Thank you. Bye-bye.
Thanks very much.
Thank you.
Bye-bye. Take part. Bye-bye.